thinking about your initial approach, you have a patient that's come in with metastatic disease. What's your initial, how do you approach treatment initially, David?
Yeah, I think for metastatic disease, chemotherapy really is the mainstay of treatment. I think our Japanese colleagues made a very important contribution with a trial called Regatta, where they actually looked at whether or not gastrectomy contributed to outcome. Should patients with small volume metastatic disease undergo gastrectomy first and get chemotherapy later, or just get chemotherapy? And that study actually showed no survival advantage for gastrectomy. So typically, and actually patients did worse when they got gastrectomy. They had poor chemotherapy tolerance. So for metastatic disease, we typically start with chemotherapy. There is global consensus that we combine a fluorinated pyrimidine with a platinum agent. Increasingly, oxaliplatin has become the platinum agent of choice, both for convenience and toxicity. And some randomized trial data consistently show better outcomes for oxaliplatin over cisplatin-based treatment. Whether we do infusional 5-FU, which can be typically a 24, 48-hour schedule every 2 weeks, we really have moved away from the 4 or 5 day infusion schedule, or oral fluorinated pyrimidines, which would be capecitabine in the West or S1 in Japan, which are probably of comparable efficacy. So a fluorinated pyrimidine plus a platinum agent would be frontline treatment. And response is in about 50% of patients. Patients usually on treatment for about 6 months with median survival times of about 10 months. We'll talk later about salvage options and whether or not we should consider incorporating other agents, other chemotherapy agents into frontline treatment. And there's pretty much consistency, I think, in practice globally now.
What do you think, Dr. Shi?
Yes, actually, the treatment strategy in metastatic disease is very similar. So first, we do not use triplet regimens because our Japanese JCOG trial did not show the benefit of DCS, docetaxel, cisplatin, and S1 compared with S1 plus cisplatin in terms of overall survival and PFS. So we usually use doublet chemo, including S1 or capecitabine, or mainly oxaliplatin. So we also use infusion of 5-FU patient has a dysphagia. So I think it's very similar. So going back to the previous question regarding the PD-L1 test and MSI testing, I do it routinely. So HER2 testing, PD-L1 testing, MSI testing, as well as the NGS testing in not a few cases. PD-L1 is still controversial, but I think this is one of the clinical factors may change their treatment strategies. So I think it's very similar.
Very similar. Well, it's interesting because we have these chemotherapy regimens that we can use up front now that have relatively high response rates, decent response rates. It's not leukemia, but it's decent response rates. And we have a lot of these patients that come in with GE junctional cancers or gastric cancers who are symptomatic for one reason or the other. Manish, do you think radiation plays a role here? Do you think our chemotherapy regimens are good enough? How do you approach these patients?
Right, for metastatic.
Yeah.
Yeah, so great question. So radiation can play a role from a palliative standpoint. So if you have a bleeding tumor, for example, so that's not an uncommon thing where you have a gastric mass that has some amount of blood loss. So you can do palliative radiation to help control the bleeding before or as you start systemic chemotherapy. GE junction tumors can be associated with dysphagia. Often chemotherapy is actually active enough that it can actually lead to dysphagia relief quicker than you can with radiation. So I don't typically use radiation for the initial management of dysphagia. I try chemotherapy first. There was some discussion about 3 drugs versus 2 drugs, and I just wanted to touch base on that a little bit. So, I obviously agree that a oxaliplatin 5-FU based treatment is standard. There has been controversy because historically epirubicin platinum 5-FU was considered a very active 3-drug regimen. I just wanted to state for everyone and all our viewers that we really don't think of epirubicin as active in gastric and esophageal cancers. It doesn't add that much activity, and it adds a lot of toxicity. And there was a randomized study in the neoadjuvant setting that compared cisplatin 5-FU versus epirubicin cisplatin 5-FU, and there was no difference in outcome. So based on that, we really don't use epirubicin. So then the only other 3-drug regimen that we would consider involves docetaxel. And there is the FLOT regimen, FLOT, which has a lot of activity, and we should talk about that further, as well as the DCF regimen, docetaxel cisplatin 5-FU. And people have done different modifications of it to make it more tolerable. So the modified DCF regimen is very similar to FLOT, except for cisplatin versus oxaliplatin. Those two regimens probably are a little bit more active in terms of response rates. Response rates are 50 to 55%. But Kohei made a very good point that when you are able to get second-line therapy, then you're ending up getting all the drugs over the course of the patient's care, as opposed to putting it all up front. So I think most of us think that that's why a 3-drug regimen may not be that important or that active. And that's also what we're seeing here in the United States and in Europe, that more and more people are getting second and third line therapy. So you may not need to use all your guns up front. So I totally agree that a 2-drug regimen makes a lot of sense.